Hello and welcome to this EMJ Diabetes webinar, focusing on inter-organ communication in obesity and the role of adipose tissue in type 2 diabetes. My name is Evgenia Kutsuki and I'm the editor of the EMJ family of journals. Our presenter today is Gijs Goossens, Associate Professor at the Department of Human Biology, School of Nutrition and Translational Research and Metabolism at Maastricht University Medical Center in the Netherlands. Gijs's current research centers around the impact of dietary, exercise, and pharmacological interventions on improving metabolic health, with a focus on healthy aging. Gijs has received several prestigious awards for his work and has served as president, chair, and vice chair of several international organizations involved in the study of diabetes. Thank you very much for joining us today to present this webinar, Gijs. I'm now passing over to you, and I look forward to watching your presentation.
So thank you for this kind introduction and the invitation to talk to you about inter-organ communication in obesity. And in particular, I would like to discuss the importance of adipose tissue dysfunction in the development of insulin resistance and type 2 diabetes. So briefly, I will explain that insulin resistance is a key factor in the pathophysiology of type 2 diabetes. And thereafter, I will discuss the relationship between body composition and metabolic health. And finally, I will elaborate on the importance of adipose tissue dysfunction in obesity-related insulin resistance and type 2 diabetes. So clearly, obesity is the result of a prolonged positive energy balance. So weight gain will occur when energy intake exceeds energy expenditure for a prolonged period of time. However, it is very important to realize that obesity is a complex, chronic, multifactorial disease. In other words, several internal and external factors play a role in the development of obesity. And of course, we know that diet as well as physical activity are very important factors that determine energy balance and as such weight gain. Physical inactivity might be even more important. That is also related to the urbanization, but we should also not forget about factors such as stress and sleep. So not only sleep duration, but also sleep quality impacts metabolism. Of course, genetic factors do play a role, but a very important factor that should also not be ignored is the use of medication that might also contribute to body weight gain. And we know that at the population level, BMI is also related to a lower life expectancy. So that is also the reason, I think, why we should worry about obesity. And this is data for men. More than 500,000 men were included in this analysis. And what you can see here on the x-axis is the age of the individuals, and on the y-axis the proportions of individuals still alive. And the different lines represent the different BMI categories, so ranging from normal weight to morbid obesity. And what you can take from this figure is that people with a BMI between 22.5 and 25 kilograms per square meter, in other words, normal weight, have about 80% chance of reaching the age of 70 years old. When you increase BMI to a BMI between 35 and 40 kilograms per square meter, there is only 60% chance of reaching age 70. And when we then look at the red line, so morbidly obesity, a BMI between 40 and 50 kilograms per square meter, there is only 50% chance of reaching age 70. And if I would rephrase this, this means that mean survival is reduced by 8 to 10 years. And now we're looking at life expectancy, but in my opinion, quality of life is even more important than life expectancy. And we know that obesity is a major risk factor for the development of several chronic diseases, including cardiovascular disease, type 2 diabetes, liver steatosis, and also several types of cancer. So let me first explain in a little bit more detail how type 2 diabetes develops. And insulin resistance plays really a key role here. So insulin usually increases glucose uptake in skeletal muscle, and it reduces glucose output from the liver. So when insulin resistance develops, one would say that there is actually a lower suppression of hepatic glucose output and lower uptake of glucose from skeletal muscle, which might lead to increased blood glucose levels. However, this is not immediately the case. So although there is insulin resistance, fortunately, the pancreas can compensate by just producing more insulin. So by having this hyperinsulinemia, more insulin secretion from the beta cells in the pancreas, blood glucose concentrations can still remain normal. But you can imagine when this process continues over time, with worsening of insulin resistance, there comes a moment in time when insulin secretion is insufficient to maintain euglycemia. And that's the moment when blood glucose concentration starts to rise. And it's not until progressive beta cell dysfunction occurs that there will be a sharp rise in blood glucose concentrations, and as such, type 2 diabetes will develop. And I like this slide a lot because it also shows a large window of opportunity here on the left-hand side of this figure. So what I mean with that is, if we better understand how insulin resistance develops, we can actually develop and optimize our intervention strategies. And also when insulin resistance is already present, we can actually develop interventions to reverse insulin resistance. In other words, to improve insulin sensitivity, thereby lowering the risk of development of type 2 diabetes. And we know that at the population level, the body mass index is a pretty good indicator of cardiometabolic health. But at the individual level, this is not always the case. And of course, what I show you here is a rather extreme example. Two people with a similar BMI, but the person on the left-hand side clearly has abdominal obesity, and on the right-hand side, this bodybuilder has hardly any fat mass, but a lot of muscle mass. So we know, of course, when we talk about high BMI and cardiometabolic disease risk, it's really the fat mass that matters. It's not muscle mass, but if you have excess adipose tissue, that presents a risk to health. But fat mass, at the same time, is not necessarily related to insulin resistance at the individual level. And I will show you some examples here. So there are individuals, and I'll come back to that in a minute, that do have a BMI above 30 kilograms per square meter, so have obesity, but metabolic health is still relatively normal. Furthermore, when patients undergo liposuction, in other words, the surgical removal of adipose tissue, sometimes up to 8 kilograms of fat mass is removed, there is no change in insulin sensitivity whatsoever after surgery. Another example is patients treated with thiazolidine diones, shortly TZDs, that are insulin sensitizers. But although insulin sensitivity improves, there is substantial weight gain and body fat gain, especially during the first year of treatment. So we have a situation here when there is more adipose tissue mass, but also improved insulin sensitivity. And finally, we have patients with lipodystrophy, so congenital or acquired lipodystrophy. And these patients have hardly any subcutaneous adipose tissue, but are severely insulin resistant. And most of these patients will develop overt type 2 diabetes. So these examples clearly indicate that there is no direct relationship between adipose tissue mass and the metabolic health of an individual. And we know that it's not just about the amount of adipose tissue that one has, it's about body fat distribution. And we know that abdominal obesity increases the risk of developing type 2 diabetes and cardiovascular diseases, whereas interestingly, when you store fat at the lower part of the body, that might even confer protection against the development of chronic diseases for a given BMI. And just to illustrate that, I would like to show you some data from the InterHeart study. So that was a study in which more than 27,000 participated from 52 different countries. And what you can see here in this figure is on the x-axis the body mass index, and on the y-axis the risk for an acute myocardial infarction. And per BMI category, you actually can see the quintiles of waist to hip ratio. So I'll guide you through this figure. So in general, you can see that with a higher BMI, the odds ratio, so the risk for acute myocardial infarction, increases. However, when we look within each BMI category, it's quite interesting to see that a high waist hip ratio, even in the BMI category of normal weight, so let's say the BMI between 20 and 23, people with a high waist hip ratio have a higher risk of a myocardial infarction as compared to people with a BMI above 30 but with a low waist-hip ratio. So this clearly indicates that body fat distribution is more important than total fat mass when we talk about myocardial infarction in this case. But the same holds true for the risk of developing type 2 diabetes. So it's not the total amount of body fat that matters, it's where the fat is located. Abdominal obesity increases the risk of cardiometabolic diseases. But we can have two individuals with a similar BMI, a similar body fat percentage, and also a similar waist circumference. In other words, a similar body fat distribution. So both individuals can be abdominally obese, but have a different metabolic health. And when I say metabolically healthy, that is usually defined as the absence of hypertension, the absence of dyslipidemia, and the absence of type 2 diabetes. And this is also nicely illustrated by data from the group of Matthias Blur in Leipzig, published more than 10 years ago. So what you can see here on the x-axis again, BMI, and on the y-axis, insulin sensitivity. So in this total population, I hope you can appreciate that with a higher BMI, insulin sensitivity is lower. In other words, people with a high BMI would have a low insulin sensitivity. However, when we look within a certain BMI category of obesity, in this case, a BMI, let's say, of 45 kilograms per square meter, so morbid obesity, you can see that there is huge inter-individual variation in insulin sensitivity. So you do have individuals with a BMI of 45 kilograms per square meter that have a very low insulin sensitivity here at the bottom of this graph. In other words, insulin resistance is present. Whereas there are individuals also with a BMI of 45 kilograms per square meter with a relatively high insulin sensitivity. In fact, insulin sensitivity is not different from a lean reference population. So what I'm trying to say is that the outside does not tell everything. Two people can have a similar BMI and body fat percentage and a similar body fat distribution, but can have differences in metabolic health. And we know that 10 to 30% of the people with obesity are considered to be metabolically healthy. However, and I think this is a very important message, individuals with obesity, but at a certain moment in time still a metabolically healthy profile, do have an increased risk for type 2 diabetes and cardiovascular disease development. And that is also what is the conclusion of the meta-analysis that I'm showing now. So this paper, this meta-analysis, was published about 7 years ago. So all studies included here were actually including people with obesity, but with a metabolically healthy profile at baseline. And all these individuals were followed on average for 7 years. And the main conclusion from this meta-analysis is that people with metabolically healthy obesity do have a 4-fold increased risk of developing type 2 diabetes later in life compared with healthy normal weight adults. So clearly, obesity does present a risk to developing chronic diseases later in life. But how do we explain that two individuals, as I said, with a similar BMI and fat mass and also a similar body fat distribution can still have differences in metabolic health? When we should not only look at the outside, we also should look at the inside, namely adipose tissue function. How is the organ working, and is it working properly? And when we look at adipose tissue function, we can ignore the fat cell, the adipocyte. And we know that during a prolonged positive energy balance leading to weight gain, that these fat cells will enlarge. So you will develop adipocyte hypertrophy in most cases. And this is also what you can see on this slide. This is data from our own work, published about 10 years ago. So what we did, we took adipose tissue biopsies and we made slices there and took pictures. And I hope you can appreciate that the fat cells of the obese donor in this case, on the right-hand side, has much larger fat cells than the lean control individual on the left-hand side. And why is this important? Well, we know that abdominal subcutaneous fat cell enlargement is an independent marker of insulin resistance, and it even predicts the future development of type 2 diabetes. So why is that? Well, then we have to zoom in on what's adipose tissue function actually? What is the function of these fat cells? Well, we know that a large proportion of the dietary fat is actually stored in the adipose tissue. However, you can imagine that when obesity develops and these fat cells become enlarged, that the lipid buffering capacity is reduced. These fat cells are already overloaded with stored triacylglycerol, so stored lipids, and therefore these fatty acids cannot be stored as efficiently in the fat cells. And the same is actually true in patients with lipodystrophy I was referring to before. So if you don't have the fat cells, where do you store the lipids? Well, in other organs. And that is exactly what is happening also in people with obesity. So due to the reduced lipid buffering capacity of adipose tissue, there is an excessive flux of lipids towards non-adipose tissues, such as the liver, the skeletal muscle, the pancreas, and the heart. And we know that lipid accumulation in the liver and skeletal muscle is associated with insulin resistance. That lipid accumulation in the pancreas might be linked to beta cell failure, so an impaired capacity to produce and secrete insulin. And lipids accumulation in and around the heart has been linked to cardiac dysfunction. And in addition to this important function in lipid metabolism, we know that adipose tissue is an endocrine organ. In other words, the fat cell produces and secretes a variety of factors, many factors, that do play an important role in many physiological processes, such as the regulation of blood pressure, the regulation of appetite, lipid metabolism, but also glucose homeostasis and inflammation. And we know that inflammation can also contribute to the development of insulin resistance. And we know that this endocrine function of adipose tissue is impaired in obesity and type 2 diabetes. So we also see that adipose tissue is more inflamed in people with obesity and type 2 diabetes. And when we talk about inflammation, we should not only look at the fat cell. There are more cells present in adipose tissue, so a variety of immune cells. And we know now that there dynamic changes in these immune cell populations occur during the development of obesity. So in patients with obesity, we see that when these fat cells are enlarged, more pro-inflammatory immune cells have infiltrated the adipose tissue. And there is evidence now, mainly from rodent studies, but also some evidence in humans, that these pro-inflammatory immune cells can also contribute to the development of insulin resistance. So just to summarize what I've told thus far, we know that during a prolonged positive energy balance leading to weight gain, fat cells will enlarge. And these hypertrophic adipocytes show impairments in lipid metabolism, alterations in the secretion of these factors produced from the fat cells, adipokines as we call it. Immune cells infiltrate the tissue. This leads to a pro-inflammatory phenotype and insulin resistance within the adipose tissue. But this has also important implications at the whole body level, because we know that these lipids can spill over in the circulations because they cannot be efficiently stored in the adipose tissue, and these lipids might then accumulate in other organs, causing insulin resistance and other complications. And the same might hold true for these inflammatory factors produced by adipose tissue. This might contribute to systemic low-grade inflammation, and this might also impact organ functions such as, for example, skeletal muscle and the liver. So to come back to this concept of the metabolically healthy obese individual, we know now that indeed when there is a BMI above 30, but people still have a relatively normal metabolic profile, that this is also due to the fact that the adipose tissue is still functioning quite normal. So there is no enlargement of fat cell size. Inflammation is normal as compared to normal weight individuals. These individuals seem to have a normal lipid storage capacity, and therefore insulin sensitivity is still fairly normal. And there is less fat storage in the liver and less fat storage in muscle. And therefore, these individuals do show this relatively healthy metabolic profile compared to people that have already hypertrophic adipocytes. In other words, larger fat cells that leads to more fat storage in the liver, in skeletal muscle, and also more visceral fat. So this brings me to my take-home messages. First of all, obesity is a chronic relapsing disease, which in turn acts as a gateway to a range of other complications and non-communicable diseases. BMI, total body fat mass, and also body fat distribution are very important determinants of cardiometabolic health at the population level. But we know that adipose tissue dysfunction is strongly related to insulin resistance and the risk of developing chronic diseases at the individual level. So phenotyping beyond body mass index is really needed to better assess cardiometabolic risk and disease risk at the individual level, and also to optimize our intervention strategies. And although I did not talk about that much in this webinar, I cannot finish this symposium by not stating that obesity should be really prevented and treated using a holistic approach. So taking not only the biological factors into account that I was talking about today, but also social, cultural, economic, and environmental factors. Well, and science, of course, is teamwork. So I'd like to thank my research group at the Department of Human Biology of Maastricht University Medical Center in the Netherlands, and also the EFSD and the Dutch Diabetes Research Foundation for the financial support of our work. And last but not least, I would like to draw your attention to, I think, a very exciting International Obesity Congress, which will be held in Maastricht, the Netherlands, from May 4th to 7th next year. And this symposium offers, I think, a unique opportunity to share exciting new research findings and discuss these with colleagues working in the field of obesity and its complications, including people that are focusing their work on type 2 diabetes. So I hope to welcome you, many of you, in Maastricht next year. So thank you for your attention.
Thank you, Gijs, for this excellent presentation. That was really great. And I'm sure our audience also found this very interesting. We can now pass on to the question part. And we have a number of questions submitted, so I'll get started with these. So you mentioned the body fat distribution is an important determinant of the risk of developing type 2 diabetes. What is the importance and relevance of subcutaneous and visceral fat for patients with obesity with respect to type 2 diabetes risk?
Yeah, I think that's a very important question. And what we have learned from a lot of epidemiological studies is that there is in general a stronger association between the amount of visceral adipose tissue mass and the development of complications and non-communicable diseases such as cardiovascular disease and type 2 diabetes compared to the amount of subcutaneous adipose tissue. Although some studies, as I also pointed out, also show a clear link between the amount of subcutaneous fat mass and the development of these diseases. But I think it's important that visceral adipose tissue, in my opinion, is also an ectopic fat depot. So if your subcutaneous adipose tissue is not able to efficiently store dietary lipids, for example, these will spill over not only to muscle, liver, pancreas, and the heart, but also to the visceral adipose tissue. So what I'm trying to say is that maybe the reason for an increased visceral adipose tissue mass might be dysfunctional subcutaneous adipose tissue. And I think that is very important to realize. So I believe that dysfunction of subcutaneous adipose tissue might be the culprit of several chronic diseases, including type 2 diabetes.
Thank you. And could you please comment on interorgan communication between muscle, fat, and brain compartments?
Oh, that's an intriguing question. I mean, we know, of course, a lot already about interorgan communication when we talk about crosstalk between adipose tissue, muscle, and liver, and I also elaborated on that in this webinar. How, for example, adipose tissue can communicate and can actually steer and regulate metabolism in muscle and liver, for example, via the secretion of these adipokines, the factors produced by the fat cells. And I think we're at the very starting point to learn more about crosstalk between, for example, adipose tissue and the brain, skeletal muscle and the brain. And the reason for that is a lot of preclinical work has been done. So in rodents, we can study the brain more easily as compared to humans, as you can imagine. But of course, we know, just to give one example, that there is indeed crosstalk between these tissues and the brain, and also adipose tissue and the brain. When we just think about leptin, the satiety hormone, we know that adipose tissue produces leptin, and that leptin signals to the brain to actually induce satiety signal in the hypothalamus to also give the signal that we're sort of satiated and that we should reduce our food intake. So leptin is, for example, known to regulate energy balance by both impacting food intake as well as energy expenditure. But I think there's much more to be learned and to be discovered. And maybe just nice to mention also between muscle and brain, there seems to be crosstalk. So some factors produced in muscle and secreted by muscle can seem to have effects on, for example, cognitive function. I think some exciting work there. So that might be also a link between physical activity and what's happening with respect to mental health.
Okay, that's interesting, because the next question is about physical activity. So is physical activity independent protective variable across different BMIs and fat distribution types?
Again, a very interesting and important question. From my background, I'm a movement scientist, so I'm really convinced that physical activity, and the evidence shows that physical activity is a key factor in cardiometabolic health. And what might be important to point out here, I was talking about the concept of metabolically healthy obesity versus metabolically unhealthy obesity. And indeed, as I referred to in this webinar, people with metabolically healthy obesity, so a certain BMI classified as being as obesity, but still sort of a fairly normal metabolic profile. We know that there is less visceral adipose tissue mass, that the function of adipose tissue is still fairly normal, but there are also some indications that these individuals are more physically active as compared to the metabolically unhealthy obese individuals. So indeed, it seems that physical activity, and even more important perhaps, sedentary behavior, so physical inactivity, might be a very important risk factor for the development of many chronic diseases, including cardiovascular disease and type 2 diabetes.
Okay, thank you. And then obesity and dysfunction of adipose tissue may lead to type 2 diabetes in non-pregnant subjects. How will adipose tissue be involved in pregnant women that develop gestational diabetes?
Yeah, that's a question that is for me a bit more difficult to address, because many physiological changes occur, of course, during pregnancy. There is, of course, an increased adipose tissue mass also to provide sufficient nutrients to the fetus. How that is involved in the development of gestational diabetes, I think there is no strong evidence for that yet, although I can imagine that, of course, bearing in mind the functions of adipose tissue with respect to a pro-inflammatory phenotype that might contribute to insulin resistance and impairments in glucose metabolism, I think it's fairly logic to state that the increased fat mass during pregnancy might also contribute in that way, also via lipid signaling, as well as signaling of pro-inflammatory cytokines might contribute to impairments in glucose homeostasis. Although that's not my field of expertise, I must admit, but I think also other factors suggest maybe changes in physical activity pattern during pregnancy, especially towards the end of pregnancy. I think also interfere in making that association very clear, if you understand what I'm trying to say. So yeah, definitely a role for adipose tissue dysfunction there as well. Yeah.
Okay, thank you. And could individuals with lower BMI be also metabolically unhealthy?
Yes, indeed. And I think that is what I tried to point out when I was talking about the association between BMI and acute myocardial infarction, where I showed the quintiles of waist to hip ratio, so body fat distribution. And I highlighted there that in the BMI category of normal weight, so BMI between 20 and 25, so that is normal weight, normal BMI, but people with relatively more fat stored in the upper part of the body, so abdominal obesity, even it can be hidden obesity, as for example, depending on ethnicity, South Asians might have a fairly normal BMI, but a lot of visceral fat. And there the risk of developing not only myocardial infarction, but also cardiovascular disease and diabetes is higher as compared to people that might have a slightly higher BMI, but those people that store the fat in the lower part of the body might be relatively protected. So yes, body fat distribution is more important than total fat mass.
Okay, thank you. We have time for a couple more questions. So you touching on your earlier point, you mentioned the prevention of obesity using a holistic approach. Could you expand on ways in which clinicians could shift their approach to facilitate this?
I believe that clinicians should not only focus on the biological perturbations that are present in patients with obesity or type 2 diabetes when deciding on the most appropriate intervention or treatment. But I think clinicians also should take into account other factors such as socioeconomic, cultural, environmental factors, as well as patient preferences. And just to give you one example, I think a poor financial situation makes it very difficult for an individual to eat more healthily or to go to the gym, for example. If you don't have money to pay for that, right, that makes it more difficult. So a more holistic approach, I think, is really needed to prevent and treat obesity and related complications. And a clinician should also take those factors into account to make an intervention also feasible. And I'm not talking about pharmacological interventions then, but also when we talk about lifestyle changes, for example.
Mm-hmm. Okay, thank you. And you spoke about the importance of phenotyping beyond BMI to assess patient risks of developing cardiometabolic diseases. What would you say are the logical next steps for optimizing the screening and treatment of obesity? And therefore to lower the risk of developing type 2 diabetes?
So of course you need to think about something that is also feasible, right? We don't have sophisticated methodology available. GPs don't have access to MRI or whatever. So what I think as a starting point is to make very clear that it's important to take also factors such as age and ethnicity into account when you only look at BMI. We know that with aging, there are changes in body composition. So somebody's BMI can remain fairly stable, maybe overweight or slightly obese. But if that person is a bit older, or when we talk about elderly, one has to be very aware that there is, with a certain BMI that remains stable, there is an increase in adipose tissue mass going on. And I think, as I mentioned before, ethnicity should also be taken into account. So we know that South Asians, for example, are at greater risk for several non-communicable diseases compared to Caucasians, meaning that at a lower BMI, South Asians are already at a greater risk of developing these complications. So this means that we should intervene at an earlier stage. And in addition, I think that assessment of body fat distribution, which can be easily measured by just measuring waist and hip circumferences, could be done. And more detailed assessment of the metabolic and also not only metabolic, but also mental health should be taken into account. Functional status of patients, including obesity-related disabilities, should take place. So I think we should not only look at BMI, that's my main message, but also try to look at body fat distribution and other risk factors such as age, ethnicity, and also taking sex differences into account. Yeah.
Thank you. Okay, I will ask the final question that has just come in. So since we know that BMI, with all its imperfections, correlates well with increased risk of type 2 diabetes and overall mortality, why do we still need to phenotype our patients?
Yes, I think what we ideally want is to intervene with a correct, appropriate intervention at the correct moment in time. So, of course, when somebody has a BMI above 30 and is classified as being obese, we know that the future risk of developing chronic diseases is indeed increased. However, there are also some indications, and I think that's quite interesting, that certain interventions might also have detrimental effects. And also when we talk about, for example, weight loss interventions. So let's say that somebody's metabolic or cardiometabolic health is still completely normal. And this is, I'm now playing the devil's advocate, but it might be also a risk to already, for example, propose a caloric restriction for that individual, because of course weight loss will occur, and in the short term there will be cardiometabolic improvements, no doubt about that. But we all know about the weight cycling, and we know that 80% or more of the individuals will have regained the body weight within 1 year after that intervention, and then the cardiometabolic profile might be even worse as compared to the starting point. So I think we should really learn more about more personalized interventions. When should we initiate treatments, and what kind of treatment is most appropriate for that individual? And that should not be weight loss per se. I think the outcome should be improved cardiometabolic health and improved quality of life. And I think in the next 5 years, we will learn a lot more about that, more personalized approaches to improve cardiometabolic health and improve quality of life of patients.
Thank you. I'm afraid this is all we have time for today. And thank you so much, Gijs, for your presentation. And a big thank you to our audience for joining us and for your very engaging questions. Please look out for future webinars in our channel. We have another diabetes webinar coming up in February on SGLT2 inhibitors. So thank you again, Gijs. It was lovely hearing your presentation. And we'll see you again soon.
My pleasure. Thank you.